just say that really the patient right now is losing out, because in my view, the guidelines on the topic really need to be updated. I mean,
Yes.
we're
Yep.
really, I
I
think,
think we all
advocating,
agree on
yeah,
that.
yeah, and an individualized, risk-adapted approach, I think, is on the order of business, because the way the guidelines read right now, 100% of patients should not get any post-hospital discharge prophylaxis.
And just for the sake of the audience, I'm glad you brought up guidelines. It's important to always discuss them. Which guidelines are you referencing?
These are the American Society of Hematology guidelines in 2018, so they're only a year old.
Yeah, well, it's tough to keep guidelines up to date these days. The data is just coming in all aspects of cardiovascular medicine at a furious pace.
Deepak, just though to finish this piece.
Finish it.
So I think for me, the most important point is, to the point of the guidelines, is the paradigm change. And I think the benefit patients are going to get and the impact we're going to have on population health and reducing the burden of VTE is going to be achieved by prophylaxing patients who historically we weren't giving prophylaxis, and we have talked about how to select them. And the choice between betrixaban and rivaroxaban is going to be very marginal in terms of the difference that it's going to do. So what's available to the doctor, what they're comfortable with, if they use rivaroxaban for other things, they're very comfortable with it. The 10 milligram is a approved dose that's on many formularies right now. So I think that, again, if it's available to you, I think it's much more important to be changing towards, identifying those patients that should get this prophylaxis and giving it. And the differences between the drugs are more academic at this point than.
No, I absolutely agree. I mean, like most debates, really, the truth is right in the middle, as you guys all agreed.
Get to know one drug really well.
That's what I was going to say. And, get comfortable with something for this indication, and then the patient wins.
Yeah, no, that's really good advice. What about warfarin? Any role here at all? It is cheap. It's familiar. Doctors hate it, but on the other hand, they always ask about it.
Yeah, I think the problem with warfarin is the bleeding that we mentioned. We're all worried about the bleeding that patients might experience on it. They're going to be on it even for extended duration for a limited amount of time, and there's a period of time where we're trying to get that INR into the target range, and there are two issues about that. We want them protected right away, and we don't have time to wait. A lot of that risk, as Alex talked about, is in those few days after they're discharged, even the month after they're discharged. And the other issue is they can be super therapeutic and have a risk for bleeding, which is not what we want for our patients either. So I don't think, there aren't good data to support it, and the DOACs basically make the conversation rhetorical. I mean,
Yeah, no, I think you're quite right. That summarizes it very well. What about a patient who comes in that, let's say, they've got an ischemic cardiomyopathy, they're in with heart failure, they got a stent, 2.5 months ago, they're on aspirin and clopidogrel, let's say. What exactly do we do with that patient? Should we add on this extended duration? Should we not do it? How do we treat those patients? Does anyone have any opinion or data or strong feeling?
Well, we know that dual antiplatelet therapy is actually one of those 5 key high bleeding risk criteria that we saw in Magellan, and I believe also in Apex as well. So we do have some data suggest that, in addition to even a low dose anticoagulant, may predispose the patient for bleed risk. I guess the question is, and talking to my cardiology colleagues, is there a way we can remove one of the antiplatelet agents as the first order of business? And if the answer is no, then again, from my point of view, that probably would be a patient that we would consider mechanical methods of prophylaxis.
Yeah. So the dual antiplatelet patients were not enrolled in the Mariner study, for example, because of the bleeding risk and so on. So I think you need to manage first what their cardiac stuff is, and then think. And so for the in-hospital phase, you can add mechanical prophylaxis without any added risk of bleeding.
And what about if they're on aspirin monotherapy, say because they had an MI 4 years ago?
Those patients were allowed.
Happy to add it on there.
Yeah. As a matter of fact, 50% of patients in Mariner were on a single antiplatelet therapy, mostly aspirin.
Yeah, we had that too.
This talk about warfarin made something else pop into my mind, going back a little bit and talking about inpatients and heparin, and I'd mentioned or asked before about outpatient use as well of low molecular weight heparin. What are your thoughts about what's going on with the heparin shortage? I know at our hospital it's been a bit of an issue. You know?
So I was on that committee. No, it's been a major issue because we've had to come up with a set of guidelines of what to substitute, and I think this is an opportune time for us to rethink why we're using heparin at all for prophylaxis. Unfractionated heparin's not been shown in meta-analyses to be as good as enoxaparin, and we have the direct oral anticoagulants that seem to be a great option. This might be a very opportune time to work in what we probably should be doing anyways, which is switching to oral anticoagulants that have great safety and great efficacy.
Tell an 80-year-old, well, get 3 injections of heparin in your belly every day for 4 or 5 days versus a pill. Yeah. That's not a difficult choice.
Right, though it has at least, maybe the heparin shortage is changing it, but until then at least it's still a common practice in many hospitals.